Hello, everyone. My name is Jim Duquetis, and I'm pleased to welcome you to the PAUSE virtual study team. I will try in the next few minutes to give you a brief overview of the study, why we're doing it, and some of the things that you'll need to know about it when you're using it as a basis for the trial at your site. So this is what we've seen a lot of during the pandemic, and the question is, how much of this will continue after the pandemic? We know that in the area of perioperative medicine and perioperative anticoagulation, virtual care is really well suited to delivering care for patients, especially if they have multiple appointments or if they are remote. And I think it's a good way to deliver care. And that's the objective of the PAUSE virtual study, which is to look at delivering standardized perioperative management virtually in two cohorts of patients who are either taking warfarin or a direct oral anticoagulant, or DOAC, and need an elective surgery procedure. The two cohorts are about 850 patients, and they are involving patients who are having warfarin or DOAC therapy for atrial fibrillation or flutter, and the intervention is virtual interruption and resumption of warfarin with or without heparin bridging in the warfarin cohort, or virtual interruption and resumption of a DOAC in the DOAC cohort. Now, this approach really has the potential to be very efficient and very patient-friendly standard, but before we can get to there, I think we need to show reliably that virtually administered standardized perioperative anticoagulant management is safe, with acceptably low rates of stroke and bleeding, and easy to apply in practice, and perhaps most importantly, acceptable for patients. The foundation for the PAUSE virtual study is based on our prior work that many of you have contributed to in the form of the BRIDGE trial and the PAUSE study, and these studies provide the benchmark for what we think is safe perioperative management involving patients who are receiving warfarin or a DOAC. The management protocols of these trials have been incorporated into clinical decision tools that are available online in places like Thrombosis Canada. So given that, one, perioperative anticoagulant management and heparin bridging protocols are standardized, and now there's an easy-to-use online point-of-care management app available that incorporates these protocols, it would make sense that PAUSE Virtual is an opportunity to apply these evidence-based protocols alongside user-friendly point-of-care tools to assess the safety and acceptability to patients of virtual perioperative anticoagulant management. The aim of the study is to demonstrate that patients who are receiving anticoagulant therapy and need an elective surgery or procedure can be safely managed virtually without the need for in-person visits. The study design and hypothesis: the design is a prospective management study assessing standardized perioperative management in two cohorts of patients who are receiving warfarin or a DOAC and require an elective surgery or procedure. The hypothesis is that virtual management will be safe for patients based on benchmark values where the postoperative rates of stroke systemic embolism are less than or equal to 0.5%, and rates of major bleeding are less than or equal to 1.5%. So the study has a sample size of about 850 patients in each cohort to have at least 90% power at the 95% level of significance to reject the null hypothesis that the observed rates are greater than or equal to 1.5 for stroke systemic embolism, or greater than equal to 3% for major bleeding in each cohort. So which are the patients that would be eligible for this study? These are adults with atrial fibrillation flutter who are receiving long-term anticoagulation with either warfarin administered to achieve an INR of 2 to 3 or one of the following DOAC regimens. And these patients require an elective surgery or invasive medical or surgical procedure. Now, I should point out that the patients would be enrolled only if the physician is comfortable adopting the perioperative management of the bridge trial for patients on warfarin and the management of the pause study for patients on a DOAC. Although I think the impression is that these protocols are widely used in everyday practice, and most clinicians are comfortable using them. So I think this part will be easy to adapt into the PAR's usual study. So with warfarin patients, the protocol is very simple. It allows stopping warfarin 5 days before the procedure with or without heparin bridging. And among DOAC treated patients, the protocol is a little different because it is anchored on the bleeding risk of the patient. So the DOAC is stopped either 1 or 2 days, depending on the bleeding risk. And there is an exception involving patients who are on dabigatran, not many of them, with a creatinine clearance less than 50, where you stop 2 to 4 days before. Now, which patients are not eligible for the pause virtual study? These include patients in whom their reason for anticoagulation is not atrial fibrillation or flutter, so they may have a mechanical heart valve or venous thromboembolism. And if you're wondering why, well, part of this is that because in the context of a clinical trial or study, we want to try to have a uniform patient population. And ultimately, we hope that these results from the population of atrial fibrillation, which is by far the largest population among people who are receiving long-term anticoagulation, can be applied to those people who are receiving anticoagulation for a mechanical heart valve or venous thromboembolism. So we're not going to be looking at patients who are receiving a higher intensity regimen of warfarin or a lower intensity of patients who are receiving rivaroxaban. So only those patients who are receiving a dose regimen for atrial fibrillation and stroke prevention. And we exclude patients who are using a DOAC who have severely impaired renal function, as well as those who have cognitive impairment or a psychiatric illness, and those who are unable or unwilling to provide consent for virtual care, in whom, of course, in-person care will be provided. And finally, we don't want to be double counting or double enrolling patients, so they can only participate in this study once. This is the intervention. I'm not going to go through this in much detail because I think you're familiar with it in your previous management of patients who are receiving warfarin and may require its interruption for an elective surgery or procedure. And some of them may require heparin bridging, typically with a low molecular heparin. And as I mentioned earlier, among those patients who are receiving a DOAC, that the interruption interval is predicated on the bleeding risk. So 1 day off if it's a low, moderate bleeding risk surgery or procedure, 2 days off if it's a high bleeding risk surgery or procedure. And again, after the surgery, the bleeding risk determines when to resume the DOAC. So standardized, well-established protocols for perioperative management of the warfarin-treated patients or DOAC-treated patients. In terms of the follow-up after they have their procedure, you can see that this will occur over about a 1-month period, where the follow-up, of course, is by telephone. And if the patient requires an in-person assessment throughout this time, of course, this will be available as per the patient's standard of care. And this follow-up is very similar to what was done previously in the bridge trial and in the pause study. The outcomes are clinical, mainly no laboratory outcomes to keep it really simple. That includes stroke, systemic embolism, and major bleeding as the primary outcomes. And the secondary outcomes are less severe types of bleeding and other types of cardiovascular events, myocardial infarction, venous thromboembolism, and of course, all-cause mortality. We also are looking at cost effectiveness because we think that a simple virtual way to deliver care will be a lot more efficient in terms of utilizing healthcare resources. And we will try to make this really simple for you so that it's not a lot of onerous data collection about things like patient time and travel costs, but this will be done in a way that is easy for coordinators and research staff to provide the requisite data. And then finally, during one of the telephone follow-ups, we would ask you to provide a patient satisfaction survey based on a easy-to-use 5-point scale and how they felt about receiving virtual care. Of course, this is important because we want to ensure that patients are comfortable with this type of healthcare administration. Overall, we hope that Pause Virtual at the end will shift perioperative anticoagulant management from a resource-intensive in-person model to a patient-friendly virtual model. But we need to show that this approach is safe, it's easy to administer in a healthcare setting, and above all, it is acceptable to patients. If we are successful, I think we will establish a standard of care option for at least 200,000 patients a year in Canada alone. And as with the Pause and the Bridge studies, these protocols have been adopted internationally by many countries. So I want to thank you for your collegiality and participation in the Pause Virtual study. We will be having regular get-togethers with myself and our research coordinating team. And I look forward individually to speaking with you, and when the opportunity arises, to meet with you in person. And thank you for your participation and collegiality. I want to leave things on a bit of a light note. We talk about pause, but pause can also refer to a different thing. In this case, furry friended pause. So with that, I'll thank you again very much for your attention and look forward to your participation and collegiality in the Pause Virtual study.